Hi, Kerry.
Hello, Rob. How are you?
I'm not too bad, thanks. Welcome, everyone, many of whom was a fantastic pre-start of meeting number to see already there. And it's particularly good to see the first speaker and keynote speaker as the first face that I saw when I joined. So
Yes, it gave me the option of starting the meeting. I thought, I'm not sure if I'm meant to do that or not, but I pressed the button anyway.
fantastic, thank you. Thanks, Astrid, for sharing the agenda. Could you make it a tiny bit bigger, Astrid? Sorry, I can. It might just be my eyes, but
yes, of course. I could see there's 34 people already on.
That's great. Now, I'm going to wait a little bit, but only a little bit, because I'm conscious we've only got an hour, and there's a lot to pack in, and therefore we need to make as much use as possible. But I am just going to leave it till 1 minute past, so that we can get a few more people joining us before I do sort of formal welcomes. Okay, it has ticked over to 1 minute past 1 on my laptop clock. So I'm going to kick us off and start us by welcoming everyone. People will obviously join and continue to join across the next hour, but particularly the next few minutes. I would really want to thank people for taking time out of a busy time at such a busy time of year. So thank you all and welcome. For those who don't know me, I'm Rob McCarthy. I'm the Associate Director for Long-Term Conditions at South East London ICB. I'm standing in for Helen Williams today, who's the clinical lead for CVD in the ICB, who's unfortunately unable to make it. But I've been working with Helen on hypertension for a number of years now, so I know I can channel Helen's passion about blood pressure control, if not necessarily her expertise, but we have some real expertise from our speakers and from people on the webinar more generally. So we really want to build on the success of the September webinar, which was Call to Action 1, I think, which was fantastically well attended. I think it had nearly 150 or possibly over 150 people attend across the hour. And as per that first Call to Action webinar, the focus of this webinar is a kind of laser focus to think about getting as many South East Londoners as possible who are on our hypertension register treated to target by the end of March, whilst also emphasising the huge health outcome gain that we can get by treating people's hypertension to target. We have some really great speakers and we've got some really great content today. But I think without further ado, I want to hand over to Kerry Jacob. So Kerry is the place exec lead for Lewisham. She's also the ICB exec lead for the hypertension ICB corporate objective. And Kerry's going to kick us off today. If that's okay, Kerry, I think you're driving your own slides. Is that right?
That's right, I am. And my first line was going to be to introduce myself, but that's happened. So thank you very much for that, Rob. And welcome, everybody. Really pleased to see so many people here. So let me just show that I can actually share my own screen, which is always a good starting point. Hopefully everybody can see what a set of slides now, which I'll just put onto slideshow. So, okay, lovely. So everybody see this? Everybody hear me okay?
That's
I
great,
can only
Kerry.
see you, Rob, so I'll assume that's okay. So before we go into it, I want to just be really clear about why hypertension is important to me, actually. So for me, this is primarily about health inequalities and the impact that we will have on our health inequalities. We know we have enormous health inequalities across South East London. And hypertension, or lack of control of hypertension, and the impacts of hypertension really do feed into that whole health inequalities. So as you go through this sort of, well, today, but also through the slides that I'll take you through now, you'll see that, you know, it touches on health inequalities, it touches on the prevention element of this, and the impact that it has not just on people's individual lives, which is really important, but then actually also on the financial sustainability of the system. So there's costs to a personal level to individuals, and then there's costs financial to a system. And if we can do the early intervention and prevention, we improve health outcomes, we address inequality, and we have funding available for other bits of really important prevention and early intervention. So just to sort of start with that, you know, this isn't just about controlling a number, it is much broader than that. But hypertension, why worry? So at least 1 in 4 adults in England have raised blood pressure. Not all have been detected, and certainly just speaking just for Lewisham, I can be clear that we certainly have undetected in Lewisham, and it will be the same everywhere else. It's the biggest risk factor for cardiovascular disease, contributes to half of all strokes and heart attacks, and increases the risk of developing a range of other conditions, including dementia, heart failure, and kidney disease. So the biggest risk factor after smoking and poor diet. So that sort of shows how important that is. Actually, Rob, you are just covering my words, so I'm actually just going to shrink you so I can no longer see anybody, just to be clear. Often referred to as a silent killer. So obviously people wander around with it for many years, quite often completely symptom free until something like a stroke happens. But it is eminently preventable and treatable. And this information is all coming via the British Heart Foundation. So that's why we need to worry. Impacts are huge. Now I can't get my screen to move on. Oh, there we go, sorry. Right, so I'm having problems with my equipment, but I think we're okay. So just some background local information for us. Approximately 2.1 million people in South East London, and under 250,000 adults in the South East London population, about 12%, have been diagnosed with hypertension and are on GP registers. So as of December, only 209,372 patients on the hypertension registers have a blood pressure reading that's recorded in the last 12 months. So that means we don't really know how they're getting on. 37,000 people require a BP check before the end of March this year. So that's a lot of people to get through. They can have their checks done at home, in the community pharmacy, or at the GP practices. So the NHS operating plan target for 23-24, that's quite small. But what you will spot down there is, well, a whole range. I'm not going to, even I'm struggling to see it, but in there you'll see prevention and inequalities at the bottom, which we'll go to now. So let's blow that one out. So these are the three which are really important. So you'll see increase the percentage of patients with hypertension treated to NICE guidance to 77% by March 2024. So it's there, it's writ large. It's one of the national operating plan targets for 23-24, and we are expecting it to also be there for 24-25. And as Rob alluded to earlier on, it's also one of the corporate objectives that the Integrated Care Board has signed up to delivering this year and next. So size of the prize for us, if we get this right, if we sort of optimise. So you'll see a big dip in during the COVID years, but if we just bring you along to the ambition side, if we achieve 77%, so that's an additional 29,516 patients, you start to see the avoided heart attacks and the strokes at the bottom. And those are really big sums of money that we save if we do that. And that funding is then available for other needs. We've got a growing population, we have an aging population. So actually we need to save money where we can, and we need to have it available for other areas where we know there's going to be growth that we can't control or manage. And then, as I say, on top of that, there is the very personal impact of a stroke, of a heart attack, on an individual and on their families. So lifestyle and behaviour change. And this really also speaks to the way that we're going to have to work with our population as well, actually. But smoking, stopping smoking, addressing obesity and increased body weight, moderating our salt intake, increasing physical activity, moderating alcohol, and managing high levels of stress. These are all the behavioural changes that we need to make if we're going to, or that individuals can make to sort of contribute to control of their hypertension themselves, and or to prevent it developing in the first case. But that's not always very easy to do, actually. Sometimes lives don't quite lend themselves to this, or it's just quite difficult. So we shouldn't underestimate the ask of the individual when we talk to them about this sort of thing. But again, this is just sort of some examples of what those things can do. So if you reduce your weight and maintain it to within a sort of a healthy body weight, you're going to see quite a lot of impact on what your systolic blood pressure, losing the ability to speak, a reduction in your systolic blood pressure. Ditto with the diet, reduce salt intake, and you can start to see how these things would add up, particularly if you are an individual who perhaps does have all of this featuring in their diet at the in their lifestyle at the moment. So I know that an awful lot of you will know this anyway, but these are some things from the British Heart Foundation that really help at a practice level to sort of help us sort of manage this, get people's blood pressure under control. And it's not all to do with the clinician. So maintain a register and audit your practice records regularly. Consider prioritising those who've got the highest readings, those over 180, over 110. Pharmacists really helpful, so medicines optimization and community pharmacists can play a really key role here as well. There is a BP monitoring at home program that really empowers patients actually, and also helps to perhaps deal with white coat hypertension as well, but again frees up the workload for practices. Loads of patient information we can use, and scripts to help having those motivational conversations. So what are the benefits of knowing your numbers? So as I've touched on at the beginning, a really, really important health inequality dimension to this. People in the most deprived areas are more likely to have uncontrolled blood pressure in comparison to those from more affluent areas. And we do have some very high levels of deprivation across South East London. Uncontrolled hypertension, as we touched on earlier, leads to stroke, heart disease, end-stage renal disease, and a whole range of associated costs to the community, to the individual, and to services. Particularly prevalent for people from African, Caribbean, and Asian backgrounds. They have a much higher chance of developing hypertension. And when as GPs you maintain a register in primary care, you're much better able to identify those patients, treat them and manage them before it sort of leads to the chronic illness. So knowing your numbers will help the patients to change their numbers, and that sort of the change management of people who develop hypertension is really, really important. And so numbers help them visualize, if you like, and to perhaps make the case for making those changes. Also frees up GP appointments to focus on the chronically ill patients. So another good reason to do that. I'll leave that there, and I will actually come out because I can't. That's it. So I'm having a few issues with my IT today. So hopefully what that sets out is the reason why we're here. Hypertension is really important, first and foremost for me, because it drives a health inequality, and it is driven slightly, partially by inequalities in our communities anyway. The impact on individuals are significant, and on their families. The impact on health service, both in terms of our capacity to deal with other things and also on our resources to spend on other areas where we have no control, is really, really important. As we said earlier on in the presentation, actually it's treatable, it can be managed, it can be, you know, people can come through this and can keep their blood pressure managed at a reasonable level and avoid some of those long-term impacts. I'll leave it there because I know there's a lot more detail that you're going to go into with everybody, Rob, including a whole load of data. So I will pass back to you.
Thanks so much, Kerry. That was really helpful context set. And I know because we've talked about it as the place exec lead of Lewisham, just how much of a focus you have. You're very conscious of how challenging this is as a target. We'll look at briefly at South East London kind of position and performance in a second, but how hard you're working with Lewisham stakeholders to shift the dial on this. And I know Lewisham's commitment and lens around health inequalities, which is so important as well. So thank you very much. So that I am, without further ado, going to dive into a little bit more of the data context. So Kerry set some of it out in her slides, but I'm just going to go into a bit more detail. I am going to be quick because I think there's some really important content to get to after this, but I do think a little bit of data context is really important. I'm looking at Tinu because I can see you. Have I shared the slides, Tinu? Or someone give me a thumbs up if you can see it. You should be able to. That's brilliant. Thanks, Astrid. Right, let me start. So, what does the data show us in South East London? Just to remind you of the NHS operating plan target, which is to increase the percentage of people treated to NICE blood pressure targets to 77% by March 2024. So that's 2 and a little bit months' time. But actually, what I want us to focus on is the improvement to health outcomes that this increased performance would bring, not the target itself. So I'm going to go on to the data, and I'm going to start with national data. So this is CBD Prevent data, national data, which is the latest data is to the end of September. And there just a couple of slides are going to be doing the glass half empty bit first. So here we can see South East London's performance as the black line, the All England performance as the light blue line, and there's our ambition up there as the 77% target. So you can see we are well below the 77% target line. We're also a little bit below the England average line, and we have been static in terms of our performance in the last 3-month period. So we haven't really improved from July to September, according to the CBD Prevent data. And that our performance remains at 64% blood pressure control. So that's 13% off the 77% target. And also here we are. Yes, we are currently the 5th least well performing ICS in England, but there's a huge opportunity to improve. And to take us to that 77% ambition, we would need to treat to target approximately 30,000 more people in South East London, but that is doable. Okay, so I'm going to move on to slide 6. Now we move, sorry, I'm going to move us on to slide 5. Sorry. And this slide shows the opportunity, I think. So this is hypertension register patients with no reading in the last 12 months. So if we do nothing about these patients, they will automatically contribute a fail if they're not checked. Although many of them kind of naturally, without much intervention or any intervention, will actually be achieving the target. So this figure here does represent a really big opportunity if we can get blood pressure reading done. Now I'm going to move on to the South East London local data. So this is the South East London BI hypertension dashboard. It's an absolutely fantastic resource. If you haven't used it, it's available on the ICB website, and it can also be available to people who aren't ICB employees. It is a really, really helpful resource. It drills down to borough, PCN, and practice level, so you can really get a sense of how you're doing, and it also cuts in lots of different ways. That's the end of the plug. I'll go on to the data. So it's slightly more real time. It's slightly close to real time as well. So it's up to the last full month, which is the end of December, and you can see 65.2% control. So we've got back to the high watermark that we had in March of last year, and we did dip immediately after that down to 63%. So we're slowly making our way back, not at the trajectory or pace that we would like. And yes, we are still 12% off target, but at least we have been moving slowly back towards target since June. And also we know that January to March is always the strongest performing quarter. So this slide focuses on the under 80s. Particularly, and it shows that there's variation in South East London. So variation by borough. You can see here Southwark is currently the highest performing borough at 65.6%. Lewisham, our least well performing borough, currently at 55.7%. And also, though, you can see variation at PCN level and also practice level right across South East London. We also know, however, that we're doing some really significant work in Lewisham and across the 6 boroughs to try and assist the poorer performing PCNs and practices to improve their blood pressure control. Now, Kerry showed this slide. I make no apologies for just repeating it, because I think it is the most important slide of all. This is back to national data, so back to CVD Prevent data, and it shows what we can achieve in terms of improvement to health outcomes. So forget the NHS operating plan for a second. Forget the NHS operating plan for a second and just focus on what we can do for people's health. This is where we are now. It says June 23, but we're in roughly the same position in terms of the national data. This is where we want to be, and this is what we can affect if we treat more people to target. We can save just under 180 heart attacks, just over 260 strokes, and save just over 140 deaths in South East London if we shift to 77% achievement of treatment to target. And I think that is a hugely powerful statistic. So I'm just going to summarise some of the absolutely key points before we move into the next item, where Kesel colleagues will be talking us through some things that we can do to actually make a difference and to treat people to target. But in summary, there are still over 35,000 people on the BP register who've not had a blood pressure check in the last 12 months. This represents a real opportunity. Overall, we're controlling less than 65% of people on the BP register to target. We need to treat approximately 30,000 more people to target to achieve the 77% operating plan target. And there is still significant variation actually across PCNs and across practices. Optimizing blood pressure treatment to 77% in South East London will prevent these negative health outcomes. These are real evidence-based extrapolated numbers. They show the impact that treating blood pressure to target can have. And in fact, when we go beyond the end of March, we should be even more ambitious to improve health outcomes even more. And also, it saves a huge amount of money to the health economy, which is something which, whilst it's not as important as health outcomes, it is also a very important factor to remember, given how tight money is in the system at the moment. I am going to stop sharing, and I am going to look to. By the way, in terms of questions, we've got quite a nice portion right at the end of the webinar where we can devote to questions, So I'm going to move us on, keep the pace going, and I am going to move us on now to Clinical Effectiveness South East London colleagues. For some practical things we can do to shift the dial in the next 2 and a bit months, and also beyond, importantly into next year. Tinu, Sian and Anu, I hope you are in a position to present. I don't know which one of you is sharing.
Rob, there's some small problems where Sian and Anu, they're unable to unmute their mic and get on to the call.
Oh.
So Tinu is the only person who has been able to get on to the call so far.
Can we send them another link, or?
I have resent it. I've resent the link several times, but it just doesn't seem to be working.
Okay.
I wonder, Rob, it's Nick here.
Hi, Nick.
I wonder whether I'm happy to do a bit of an intro in Sian's absence, and then Tinu, if you're happy to do a bit of a run through of the resource pack, and that way we can obviously continue in their absence.
Thanks, Nick. That's hugely appreciated, and apologies to everyone for the technical issues. The webinar. The webinar approach is fantastic in many ways, but obviously not if we can't get our speakers to speak. So thank you, Nick, for stepping in. That's hugely appreciated, and I know as a program manager for the KESSL program, you will be able to do a fantastic job. It's much appreciated.
Thanks, Rob, and hi everyone. I wasn't anticipating to speak, so I'm probably not as fine-tuned with the content, but having played a hand in obviously the work that's been delivered, hopefully I can still lead us through the initial introduction. So yeah, as Rob says, I'm Nick Harris. I'm the Programme Manager for Clinical Effectiveness South East London. And obviously, hopefully by now, those of you that are based in general practice, you'll know that we are here to provide a range of support to practices. I will just get the slides up. Can people see the slides? Can people see my screen? Oh no,
not yet.
No. Okay, one moment. Sorry about this.
That's great. It's not yet in slideshow, Nick, but we can see it.
Okie dokie, great. Okay, well, just as a quick intro, as Rob alluded to, we were hoping that Sian was going to be here today to give a quick introduction, and also joined by Tinu today, who is here and going to do a run through of the resource pack that I think you alluded to earlier, Rob. And Anu is also one of our KESSL facilitators. Hopefully some of you out in the practices that Anu and Tinu cover, which is, I think they cover across a number of the boroughs, Bexley, Lewisham, Greenwich and Bromley, between the two of them. So hopefully by now people are fairly familiar with KESSL, but we talk about KESSL as being a QI methodology that's sort of systematic and really kind of hangs together from a point of view of it being evidence-based. So we always work with practices to identify what's the most important area to support, and from there we develop some guidance. Once the guidance is delivered, then when we deliver education, we also localize various other resources such as templates. We work with data, we work with Ardens to develop local searches, and we take data packs out to practice visits. So again, hopefully people that are based in primary care are familiar with KESSL by now, but that's just a reminder of broadly what we do. We cover a range of clinical areas. We're here today to talk to you about hypertension. And as you can see from this grid, you can see that we have a hypertension guide available. We've delivered various bits of education. As I say, we've localized templates. We've got some data that we can support you with, but also Rob's already told you about the business intelligence unit data, which is accessible for which practices can access. And we also go out and we provide both practice and PCM visits. You can also see from here a range of other areas that we cover across those various functions. So just to give you a quick update around some of the bespoke support that we've been providing around hypertension. So in addition to the guides, the education, the data, we've also been providing some tailored support to practices recently. Anu and Tinu and other facilitators have been going out and supporting some of the non-clinical teams and some of the practice teams around call and recall, and we've got some really nice case studies that we can very briefly look at here, where the team have gone out and provided support around the process for calling and recalling patients with suspected hypertension. And you can see both from case study 1, after that took place, we could see a real a quick increase in the number of blood checks being picked up for the respective cohorts. And similarly, on the right hand side, we can see case study 2. Again, we can see once that support had been provided within the practice, we can see a sudden uplift. So it's really just to shine a light on the fact that in addition to some of those overarching support that we provide, we can also come out and provide that tailored support specifically for your practice or your PCM. As I alluded to earlier, we've also done some training already, both for clinical but also recently for non-clinical staff, and you can access some of the training on the Kessel web page. There's a link there, and I think there's a QR code coming up later in the presentation which you can use, and I can also drop the Kessel web page link into the chat in a moment. And then finally, and this is the main focus of our presentation today, we've also been developing a resource pack for non-clinical staff. Now, some of this is shaped by some of the training that we delivered back in October, November time, I believe. So that's really one of the things that we really wanted to walk you through today, is just to sort of give you an initial introduction to that resource. Hopefully it will be a useful exercise for both clinical and non-clinical staff, because obviously, from a non-clinical perspective, there'll be some information in there that will really help you to know how you can do things differently. But also, as a practice, it will hopefully help you to understand more about how you could really utilise the capacity and capability within your practice. I'm going to try and see if I can pivot back and see you all. Oops, I didn't mean to end the show, but I'll go back in a moment. Tina, are you happy to take the group through the next section?
Yeah, if you're happy to share the slides for me.
I will indeed. Yeah, apologies. I accidentally stopped sharing there. Bear with me a second. Great stuff. Well, over to you, Tinu, to introduce yourself.
Hi, everyone. I'm Tinu. I'm one of Kessel's facilitator. I cover Bexley and Bromley. So following on from what Nick has just mentioned, we created this pack for non-clinical team following Kessel's Southeast London webinar that we did in October. The key messages that fell out of that message is the webinar is hypertension is everyone's business, making every contact count, making sure that your blood pressure is being checked. Patients with hypertension should have a review at least annually, and patients with blood pressure reading of 180 over 120 needs an urgent assessment by clinician on the same day. Okay, next slide, please. So the big idea here is hypertension is not just a problem. So the big idea there is that hypertension is not just a problem for some people, it's everyone's business. We all need to work together to tackle it because it's a silent killer and we can stop it in its tracks. So this page can easily be understood by non-clinical staff such as receptionists, administrator, healthcare assistants, practice manager, and those in the hours role. It looks at narrative on what hypertension is, your role in hypertension care, and why you focus on it. It also looks at what blood pressure is, what it means, and why it should be measured, where you can have your BP checked, what good blood pressure control is. And for instance, I'm not a clinical person, but if I read this, I'm confident to speak to people about high blood pressure and what hypertension is. Thank you, Nick. Next slide, please. So this page is an extract from our Kessel hypertension guide. Lifestyle changes plays a crucial role in managing and reducing hypertension. Making healthy choices can help lower blood pressure and decrease the risk of complication. Here are some key lifestyle changes that can positively impact a patient with hypertension. So if someone reduces their weight, for every 10 kilograms that they lose, their systolic blood pressure approximately drops from between 5 to 20 millimeters of mercury. A reduction in salt intake can reduce their blood pressure from between 2 to 8 millimeters mercury. A reduction in alcohol intake can reduce their blood pressure from between 2 to 4 millimeters of mercury. Having regular exercise can help you lower your blood pressure and can reduce their blood pressure from between 4 to 9 millimeters of mercury. If you stop smoking, this will reduce your overall risk of heart disease and stroke and help keep your blood pressure lower. So there are a lot of different changes that can be made to help reduce your blood pressure. Thank you. Next slide, please. So this page highlights the importance of hypertension review for hypertensive patients once diagnosed. I know a lot of you might be contacting people with hypertension review. So we thought it's important that you know what is included and what patients should expect in case you're being asked. So we have tried to capture here what are the good things to do ahead of that appointment. So this is where a non-clinical person can step in to help. It is helpful to gather some information ahead by arranging the right tests. So in the blue box in front of me, you can check for recent blood pressure reading using accurate flow messages to patients to capture this own blood pressure reading. Check for smoking history, weight and height to calculate BMI, get blood tests from ready to capture the various profiles, kidney, cholesterol, and diabetes, and encourage patients to submit their urine sample as part of a kidney test. And on the other side of on my right-hand side, we have a list of what to expect in a hypertension review appointment that you can make use of. Thank you. Next slide, please. So this page is packed with recommendation of how front desk and admin team can make a difference. You can make meaningful difference in the care of a person with hypertension by taking several proactive steps. We have divided this section into 3 as seen. So the first step is first points of contact, call and recall, and booking a review. So for first points of contact, as a primary care support staff, you sit in the reception and you're the first person a patient will see. When a patient is in the waiting area, prompt them to use their blood pressure machine or provide them with a tailored form requesting this information. This surely will help. Also, if a patient is in the waiting room for something and you realize that they are hypertensive, you can check the pink alert box to see if they are due for their hypertension review and book them an appointment with your HCA nurse or pharmacist. This will help save time for calling the patient in again. It saves both the patient and the practice time. And as a team, you can focus your efforts on other priorities. Also, you can direct patients to use their local pharmacy or use their own blood pressure machine to record their blood pressure reading, as previously mentioned. Second part is the call and recall. This section talks about having a clear call and recall system in place. When possible, invite your patients with multiple conditions to one review appointment that covers all their other conditions, including hypertension. Use add-in searches and emails to identify who would benefit from a review. We have these searches on page 11. Use a range of communication methods to contact patients. This includes sending out accurate text or send out email, telephone people who don't respond to the text or emails, or you can send letters out as some people prefer to receive letters. Also, we have this Careful Hypertension webinar on our website for non-clinical teams, which explain what hypertension is and impact on overall health, understanding when to take blood pressure reading, what to do in a dangerously high blood pressure reading, and making every contact count. So do find time to watch it, as a lot of people fed back to us that they found it very useful. When it comes to booking a review, explain why a review appointment is being offered and what to expect to a patient. Arrange the right test ahead of the review appointment, book appointments at a convenient time. And also patients have told us they prefer face-to-face appointments when possible, especially for patients who are newly diagnosed. And through all this presentation, we have been talking about making every contact count. So where we have learned that every time we talk to a patient is a chance to help them, whether you are front desk or managing things behind the scene, every contact is an opportunity to collect, share information, and make a positive impact. Thanks, Nick. Next slide, please. So on this page, there are a lot of different things that you can do. Each of these boxes is self-explanatory. If you're unsure of where to start, this page provides practical starting point on how you and your team can optimize hypertension care. It's a page that supports you and also provides tips on collaboration with external team, such as community team and local pharmacy. We are not expecting you to do everything on this page, but do have a look and see what works for you as an individual, your team, and in your practice. If you would like support with anything on this page, please reach out to us. Next slide, please. Right, it may be quite complicated to find the right searches. We've highlighted some useful search to make it easier for you to identify your patients who need to be seen. You can either do it from this resource pack or let us know if you need support, and we'll be happy to come and help. On this page, you can find searches on how to improve your prevalence, how to find out your patients who are at highest risk, searches on how to make sure you achieve your QOF target, searches on how to find out patients who've not had a blood pressure check in the last 5 years. So utilize this page or let us know if you need our support. Next slide, please. So this page shows resource and links available for teams and patients, including ardent support, webinar, and a short video. So when you meet with your hypertensive patients, feel free to give them the diet line referral or email address for organization that can support them with their diet and lifestyle. You can also refer them to your care coordinators or social prescriber as well. So go through the links when you receive the pack. I think that's the last one. I think, Nick, you can come in and wrap it up on what the next step is. Thank you.
Thanks, Tino. That's fantastic. Yeah, just a final slide. Did I read rightly that Sian is now unable to unmute? Because if so, Sian, is there anything you wanted to just add to the resource pack run through that we've just done?
Hopefully you can hear me now. Sorry, there's been frantic activity going on in the background trying to kind of unmute us. So apologies not to, and thank you, Tino and Nick, for stepping in and doing all of that. Just to say that that resource pack was developed from what we learned from practice teams in South East London. And so what's been happening is the facilitators have been going in, they've been testing and trying different ways of working. And what we've tried to do is capture all of that initially in a webinar and then in this resource pack. And the thing about this resource pack is we're going to continue to refine and develop this. So this is like the first go at it. So if people have got any thoughts or comments from what they've seen today, please do share that back. We've got the email here and I'm sure we can share the slides. We're taking it to the Kessel steering group tomorrow. Any comments, if you get them back to us by the end of the week, we can incorporate those in the guide and we'll get it up onto the Kessel webpage next week. And then if you want support for your teams, then just let us know. We're really happy to come and do a general sort of session for a PCN for all the non-clinical staff, or come and do some individual work, particularly for those practices that are struggling. And if you want any help kind of finding out whether you're struggling or not, go and look at the BI dashboard. If you need help with that, we can help you. So basically, we're here to help and really want to help. And we recognise that every practice and every PCN are going to have a slightly different issue. And we want to learn from that and share best practice across South East London. So yeah, so reach out if you need any help from any of us. Anu, did you want to jump in as well and put your tuppence in on this? Now you've got
so now that I can unmute, yeah. I think I'm a practice manager by background, so I think this resource is much needed for general practice teams, especially people that sit at reception, people that do the call recall, just so they can understand why they are doing what they're doing and they can have basic knowledge of what it is that we're trying to achieve as a whole. And I think one thing that comes out from this pack and from what Rob said earlier and Kerry said is making every contact count. So it doesn't matter what your role is within the team, it's just taking that responsibility and doing just one little thing. So if somebody sort of comes back with like a high blood pressure, just signposting it appropriately, or just I think I can turn my camera on as well now. Yay, can everyone see me?
Yeah, we can.
Yes. Yeah, and then if somebody hasn't had a blood pressure check, then just making sure that we get that recorded. So just small little things that we do make a huge difference, and just to remember that when we do things every day.
And I think just on a final note, just to say, this is in this last 3 months, if you really want to do a push to kind of maximize your QOF, to maximize your performance, I think there will be some helpful tips. And we know this works. We've seen that kind of 20–30% improvement literally within a few weeks for some of the practices that were really struggling. So reach out, use the guide, it'll be ready next week, and reach out if you want any help from the Kessel team.
Thank you so much. Particular thanks to Nick and Tinu, who Nick for stepping in, and Tinu for kind of like the keeping a cool with the when the presentation was disrupted. Thank you to everyone for bearing with us while we had our kind of technical gremlins. I'm really pleased, Sian and Anu, you were able to join for the last part. I think some really fantastic information that was conveyed in there. Kessel are a fantastic resource for all of us in South East London, and that the resource guide is also hugely useful, and hopefully Tina gave you a flavour of that, but actually you can go and go and have a look yourselves and really kind of get more into the detail. Just looking at the chat, and I would absolutely, we've got a little bit of time now with Kessel colleagues to ask any questions specifically relating to that presentation, and then we were going to segue on to a more general Q&A afterwards. Just picking up some of the comments in the chat. Copy of the slides. Yes, we'll work with Kessel colleagues and do a PDF version of this and be able to get it out to everyone. I think I saw in the chat earlier that both Anu and Sian and Nick confirmed that if you Google Kessel, it will take you through to the Clinical Effectiveness South East London website, and the resource pack is on the website for people to access. Indeed, all of the slides, just to say, all of the slides actually that have appeared will be circulated. A question from Russell in Bromley. It would be good to be able to promote the Kessel resource through our GP bulletin in Bromley. I think we'd be very happy to do that. I can't see any other immediate questions for Kessel colleagues. Do drop them into the chat if you would like to. I've got a question, I think, as Chair's prerogative, if that's okay, Tinu, Sian, Anu and Nick, which is you've done a huge amount of work on the ground, and I think that is really valuable learning. You must have a sense from the kind of the high performing practices, or those that have worked with you that have seen a spike in their performance and ability to get people in and to treat people's blood pressure. Is there any learning from those kind of high performing or turnaround practices that you could share? Are there kind of top tips that they've all seemed to grasp, or is it a bit more nebulous than that?
I'll go. Shall I jump in first, and then I'll let Anu and Tina, who've done the on the ground. I think every practice has a slightly different issue, so I don't think there is a kind of one solution. So when you look on that top tips, you might go through that and say, well, we're doing 19 out of 20 of them, but hang on a minute, we're not doing this one. So I do think there is a difference. I would say there's something about having champions in your practice who take it on. So one person, whether it's a clinical or non-clinical, who said, this matters to me and I'm going to do it. But once you've got that champion, that they bring the whole team with them. So one person to take the responsibility to hold that hypertension hat, a little bit like Kerry does for the ICB, but then they work with the whole team, and they recognise it's not, you can't just do it with the GPs doing the checks. You can't just do it with one nurse taking it on. It really does have to be a whole team effort, whether that's hypertension, asthma, or whatever. I don't know, Anu, you were going to jump in and I went in there first, but.
No, of course not. I think that's exactly right what Sian said. So it's about making every contact count and using all the different skill sets that we have in our team, but also something about having a vision within the team, knowing where you want to get to as a team, and then also sharing the progress on a weekly basis or a monthly basis within the team, just so everybody in the team is in the know and they know where they're trying to go and how they're going to get there, and taking sort of advice and just tips from everyone in the team to know how we can do things differently.
Yeah, and the BI hypertension dashboard is really good. It's updated monthly. They do it like a few days into the new month. So if you're doing some work, you can access that yourself. You can see how you're doing compared to your peers. I'll put the link in. So if you haven't got access to it, you need to just contact the BI team and ask for access. It's available to all practices and PCNs across South East London. And it's a great tool. It takes a little bit of time to get used to, but once you've got the hang of it, I reckon 10-15 minutes playing, and then you're on a roll with it. I'll put the link in the chat for that. And that's a really good way way of using data. Another thing to do, use your data, see how you're doing, share that data with everybody, and ask Kessel to come and give you a hand, because we're really keen to.
And celebrate the small wins and the big wins. So when you achieve your little targets, celebrate that with the team.
Brilliant. Thank you all for contributing. I think now we've actually discovered how to unmute and allow camera. I noticed that Rachel Hudson was in the meeting, and would really appreciate Rachel if you're around, and if I can let me just allow camera and allow mic. If you should be able to unmute now, Rachel. Just from a community pharmacy perspective, I think we. Oh, you can't. No, hang on a second. Allow mic. Try and unmute now.
Yay! Okay.
Fantastic, fantastic. So yeah, just from a community pharmacy perspective, and realised just how important community pharmacy could potentially be. Were there any thoughts that you had? Sorry to put you on the spot, but any thoughts that you had about how practices can make best use of community pharmacy, not just in the next sort of 2.5 months, but going forward?
Yes, of course. So I think you all know that community pharmacies and technicians are doing blood pressure checks at the moment, and so they're doing patients can go in themselves, self-refer, but also referrals from GP practice, and they can also do ABPMs. They have to have signed up to the service in order to do the ABPMs, but many community pharmacies in South East London are doing that. And if you want to know which ones are, it's on the Cell website, so you know which community pharmacies are doing this service. The other thing that community pharmacies can really help with, and also your practice-based pharmacists can help with, is medicines adherence. So I know that a lot of blood pressure management is lifestyle interventions, but also helping patients to understand their need for their medications, and to also report any problems they might be having with medicines to you. So side effects, for example. And that's a really important role that pharmacists can play as well, as checking for blood pressures, but also managing the blood pressures as well. So please do reach out to community pharmacy colleagues and practice-based colleagues if you need some help with the medicine side of things.
Brilliant. Thanks, Rachel. And I can't see any more questions from the chat. I'm also prepared to, now we've finally got the hang of disabling the disabled mic function. I'm happy to take raised hands and questions as well. If you'd prefer to go stay off camera, that's also absolutely fine. In lieu of being able to see any hands or any questions in the chat, I should just say, I think, Astrid, one thing that you and I can do is to make sure there's been some commitments we've made in the chat, and some commitments to circulating resources and links. We'll make sure that we do that and circulate to everyone registered to the webinar. So don't worry about getting slides or links or helpful tips. We'll make sure we collate that, and we'll get those out to you after the session ends. It may be tomorrow, but we will get them out to you. Again, then if I can use chair's prerogative again, and this is I think primarily to Kessel colleagues again, if that's okay. In terms of working with our patients or community groups to improve hypertension awareness, is there anything? I know that's work that Kessel have also been in, some fantastic work that Kessel have also been involved in. Any thoughts around that? Sian, I don't know if I could come to you first.
Yeah, I mean, we did a really good piece of work with an organisation called Mabadalico, which is a Black-led organisation in Lewisham. And if you're interested, go to the Kessel webpage and look under Pathfinder, which is right at the bottom of the webpage, and it's got the Mabadalico patient engagement report. And that was quite a big thing. So that was kind of South East London wide. A survey and quite a big piece of work, but there's some really useful learning from that. And what we've tried to do is capture that in our clinical guides. So the resource pack is for non-clinicians, but if you go to the clinical guide, I think the Lewisham one doesn't have it, but the other 5 do. There is a page on what we learned from that, which is about picking up on Kerry's point earlier that hypertension does affect different communities differently, and particularly with Black African and Black Caribbean communities, we see hypertension earlier, and we see more impact. But we also know that there's more distrust and there's more issues around access. So there are some really good messages in that about what we can do as individuals to try and mitigate that. And it's around sort of having cultural humility training, making sure your systems are accessible for blood checks, perhaps out of hours. So that's kind of what we can do generally, and do go to that page on the Kessel hypertension guides. But I think at a practice level or a PCN level, it's really worth trying to create these relationships with local organisations. It might just be going to your PPG and saying, we've got a PPG meeting, what do you think about hypertension? And they will tell you what's working well and what's not working well. But if you've got a little bit more resource, perhaps at a PCN level, reaching out to organisations, because I think we need to start delivering our healthcare in a different way, and things like blood pressure checks in the community, probably much more accessible, much more cost effective, much more trusted. So is there something that you could maybe develop as a PCN as a kind of co-delivered blood pressure opportunity, maybe even thinking about group consultations, maybe getting groups of patients in and co-delivering something with a community group in a community space. So I think there are lots of options. We'd be happy to think through that. I know they've been doing some work in Lewisham with community groups. So yeah, so there's a page in all the guides bar the Lewisham one towards the end around inequalities in healthcare with some key learning, but I think it's about thinking about what can work in your practice, and PCN should be big enough to have a little bit of capacity to work, and it doesn't have to be the PCN medical director who does it. You know, maybe your social prescribing link workers have got those connections, maybe your care coordinators, maybe your pharmacy team, but maybe thinking about that sort of joint delivery with community groups that will improve access and start to work towards the kind of mistrust that there is for some people. Does that go some way to answering that, Rob? It's a bit
yeah, absolutely. That's incredibly helpful, Sian, and I think was much more than I was potentially expecting when I had the question. So really helpful. I guess we're obviously coming into the last 5 minutes. I think, notwithstanding the technical issues we had, I think these hour slots potentially really appreciated and really useful, and I'm saying that because of the high volume of people that we've had. Obviously the first two sessions had a real focus on improving blood pressure control for people on our hypertension register. I guess would just be interested if people would continue to like these webinars, maybe on a quarterly basis, and actually as we step out of the shadow of the 23-24 operating plan target, that 77% target, whether actually we can expand our focus of these webinars and think about potentially improving our prevalence, or as well as improving our control, and thinking about detection, and also coming back to Kerry's point right at the start of this, whether we take more of a lens around health inequalities and some of our population groups which aren't doing as well, and whether we can focus on that. I think from speaking to Helen, the Southeast London LTC team would be really happy to keep these going, but just be good to get a sense of the appetite from people, and also whether we should expand the focus, which I think is probably a sensible idea. So do drop something in the chat if you there's some coming in already, which I think is positive. I think we're minded to, so unless anyone is sort of vociferously against, I think we're going to continue to try and do that. So let's move us on in terms of, or wrapping up, I should say. So thank you so much to the people who have come and presented today. I think what I would focus on is just to say, yes, the target is important. Technically, it's important to a lot of people within the ICB, within the integrated care system more generally, for lots of different reasons. But I think for all of us, the reason the target is so important is not the target, but the improvement to health outcomes that we can get by improving blood pressure control in our hypertensive patients. I think you've heard some amazing opportunities to try and do things a little bit differently, or do the things that you know you probably should be doing, but sometimes it's just really difficult to do them. In terms of the presentation from Kessel are continuing to be a fantastic resource in Southeast London, and the website is a start point, but I'm sure that Sian and Tinu and Anu and Nick would be more than happy for people to reach out directly as well. I think I would also just mention in passing that in my team we're trying to release a very small, and it is a very small amount of funding to increase the AccuRx allocation to practices for the next couple of months, to maybe get some reminders out to people on your hypertension register. And we're working with the digital team in the ICB to try and ring fence that allocation. So if you're a practice that actually has hit your AccuRx messaging allocation, we're trying to work through with the digital team to allow a little bit of extra allocation to send reminder messages out to people, which hopefully is welcome. But just keep doing the great things that you are doing, and building on some of the top tips I think that we've given you. It is a tough mountain to climb in terms of the 77% target, but actually whatever we do in terms of performance in the next 2 and a bit months is going to be crucial. And you know, even if we meet or fail it, you can see from the size of the prize slide, you will have an actual evidence-based impact on health outcomes for people in Southeast London, and I think that's what we should all continue to hold on to, rather than think of this as some kind of target-driven approach, which it isn't. It's about improving health outcomes for people in Southeast London. Okay, it's 2 o'clock. Thanks so much for joining. Again, thank you so much to our speakers, to the Kessel team, and to Kerry. And have great afternoons, everyone. Do contact Astrid and I if you have any queries, but we will be getting some updates out to everyone who's registered to the webinar, as I promised earlier. Okay, thanks everyone. Have a good rest of afternoon.